Aye.
Bod ni'n cael wneud e. Mae'r teuluoedd ag unigolion am wybod yn aml sut mae cefnogi aelodau teuluoedd a nhw eu hun. A mae'n bwysig iddyn nhw teimlo bod gweithwyr proffesiynol yn eu bywydau'n clywed a'u deall. So dyn ni yn falch iawn bod yna sawl aelod o'r byd proffesiynol yma heddi. Diolch i chi am ddod. Dyn ni hefyd yn clywed gan y pobl yn y byd iechyd ag addysg bod nhw angen deall y pethau hyn yn well. Yn enwedig gan bod cymaint mwy o bobl nawr yn byw gyda cyflyrau fel hyn. Felly gyda cefnogaeth ariannol gan y loteri ynghyd â y tîm gwych sy'n lliwio lles ag adlamedd yn credu, dyn ni'n hapus iawn croesawu Dr Judy Eaton o Help for Psychology, Cathy Long fan hyn sydd yn gweithiwr cymdeithasol annibynnol, a Sophie Lehman sydd â phrofiad o fyw gyda cyflyrau yma. A maen nhw'n mynd i siarad am eu persbectif nhw ar awtistiaeth, ADHD, PDA a sut mae cefnogi pobl gyda'r gwahaniaethau hyn a'u teuluoedd. A dyma Mandy.
I can already tell that it's not going to be exactly the same. So if I leave out anything really important, please say. So good morning, everybody, and welcome to the session. So I'm just going to do a little bit of housekeeping first. We're not expecting a fire alarm today. So if the fire alarm does go off, there is actually a fire. So the fire exit is down the stairs opposite here. through the entrance way, and the meeting point is in front of the food hall by the umbrellas. So we should finish around 1. We're planning to have a break about 11:15, and there will be cakes. Toilets, ladies' toilet is just opposite us here. Gents is downstairs and to the left at the bottom of the stairs. We have a quiet room at the end of the corridor on the right-hand side if anybody feels need to take a break for whatever reason. And we've also got Carol, identify yourself. If anybody feels that they would like someone to talk to, have a supportive listening ear, grab Carol and you can go down to the room with her. We will be sharing the recording of the session this morning afterwards. So we will be doing questions at the end. So if you don't want to be in the recording and the questions at the end, just let us know. Credi is the organisation that we work for or associated with, the people who've organised this. And we support unpaid carers of all ages in Ceredigion and also Powys. We also support young carers in Wrexham, Conwy and Denbighshire. If you want to find out more about us and what we do, please speak to one of the team. So we've got Carol and Pete and myself here today. Speak to one of us and our lovely volunteers. May, do you want to identify yourself? And Melissa? Yeah. Talk to any of us about Credi and what we can offer you. And we have some information about us and upcoming events by the door. So this came about because we hear so often from parents and carers how poorly understood neurodivergent conditions and associated physical conditions are. And the impact that they can have in a family. And carers want to know how to support their family members and themselves, and they want to feel heard and understood by the professionals in their lives. And we also hear from professionals in health, local authorities and education about their own desire to understand these conditions and how best to support individuals and their families. So with the financial support of the lottery and our People Powered Wellbeing Project, we're really happy to welcome Dr. Judy Eaton from Helpful Psychology, who will be online, Kathy Long, independent social worker, who's with us in person, and Sophie Lehman with Lived Experience, who's also online, to talk about their perspectives on autism, ADHD, PDA, what good support can look like for people with these differences and their families. So I'm going to hand you over now to Kathy. Thank you.
So I'm really glad that Judy and Sophie have joined me. We've worked together for quite I'm really glad that Judy and Sophie had joined me. We've worked together for quite a few years, and I hope that this morning we're going to give you a very thorough presentation on autism and co-occurring, what it means in practice, and common misdiagnoses. However, we're not going to cover everything because there's so many different areas that we could be looking at. So the main things, as said earlier, about autism and co-occurring conditions, pathological demand avoidance, and Sophie's going to share her story of, Sophie is a brilliant autistic woman who has been through the most gravest injustices within the mental health system. So she's going to talk about what her experience is. So the first thing Was that's a video? Will it show? It should be embedded, but if not, I'll move on. So you can't. Okay. Judy and Sophie, feel free to join in, speak up if you need to. Okay. So what is autism? I see autism as a difference. It's a different social communication system. It's a different sensory experience of the world. There's a clear need to know what's happening next so we can plan for sensory social overload. And strengths include honesty, loyalty, integrity, and a strong sense of social justice. And just to add to this, and that's why I feel so passionate about this, I'm 61. I was diagnosed with ADHD at the age of 55, and then a year later as autistic. And it had been missed throughout my life. So I feel really passionate about looking at the positive side of neurodivergence, whilst also acknowledging that there are some huge struggles. And one of my struggles was getting here this morning on time, which, I mean, if anyone understands ADHD, trying to get out the front door with everything we need is just really hard work. So some people might think the autism spectrum looks like starting at one end of being mildly autistic and the other end being highly autistic. However, what it actually looks like is it is a sort of spectrum of different differences and communication differences, motor skills, movement, perception, executive functioning, sensory experiences. And a lot of those can be sort of behind the scenes. People don't realise what I'm going through or what other people are going through when they're connecting with the world. So what is ADHD? ADHD causes people to have difficulties relating their attention, sometimes causing them to become intensely focused on things that we enjoy doing and little regard for what's not so pleasurable. When individuals with ADHD become hyper-focused, they can lose track of time, misplace items of importance like car keys, blurt out unrelated thoughts when their focus is interrupted. And that can also be in communication, not knowing when to speak, so cutting across somebody, but it's not intentional. ADHD is thought to be linked to neurotransmitter differences within the brain. Judy and Sophie, do you want to come in and add anything here?
So, Kathy, I'm not seeing when the slides are changing, so I can't see which one you're up to at the moment. Are you up to the one about the with the brain on? Yeah.
Is ADHD?
Yeah. Yeah. I mean, I think I could probably talk better to the next slide, Kathy, about the vulnerabilities, because I think that ADHD itself, or the people talking about it, is a good thing, but it has almost become a sort of a diagnosis that talked a lot about on social media, and I'm not sure whether people in the outside world fully understand the challenges. You know, I think there's a lot of people talking about it in quite a kind of a humorous and a funny kind of way. Oh, it's my ADHD, you know, I've forgotten this or I've lost that. I think it goes a lot deeper than that. And I think that the busy brain, the constant having that whirring of thoughts going around in your head all the time, the anxiety that comes with it often about having got things wrong or said something out of turn. I think that also needs to be thought about. And I think if you go onto the slide about the vulnerability, I think that you've got that one, have you? I mean, I think that is a really big issue for both autistic people and those with ADHD and those with both conditions. And actually, it's really interesting to think about the overlap between the two conditions, because when I first started working 25 years ago in this area, you weren't able to diagnose autism and ADHD together in the same person. And it's only been fairly recently that it's been realised just how big the overlap is between the two conditions. In fact, the children that we see through our NHS contract, around 75–80% of those that come through are seeking a dual diagnosis. So I think that that's something to sort of bear in mind, that very often these neurodivergent conditions don't exist on their own or in a vacuum. They're quite often together. And my concern has always been the vulnerability of these young people and adults. You know, you can have sexual vulnerability, you can, people could be taken advantage of. You can have young people who end up getting involved in the criminal justice system because they're very easily led and they don't always read the situation correctly. So I think that there's, in some ways it can be a complete superpower. And the hyper focus parts of it and the ability to be creative can be fantastic, but that has to be balanced as well by some of the challenges that come along with it.
Yeah, I think it's important to note that it is a attention deficit, and I think quite often when people almost trivialize it on certain social media platforms, they don't reflect actually sort of the long and deeply rooted difficulties that people with ADHD face across their life, especially women, and the differences they have relating to different hormones and sort of period cycles and the comorbidities, but also this idea of, Judy's spoken of this before, an ADHD tax that sort of accumulates over time of all the little differences. And I think it's important to, note that it's not a trivial not concentrating, it's more than that.
Thank you. Another aspect of ADHD for a lot of people can be the fear of or actual sort of very hypersensitivity to rejection. And so it can be a person can be misinterpreted as being highly sensitive, and yet it's a very, very real issue. So people can go to great lengths to avoid feeling rejected. So, and it is part of the condition. I can't get it to move now. You can move it down. That's it, thank you. So many autistic people also have attention deficit hyperactivity disorder, possibly up to 80%. So if you think about what Judy said, when a long time ago, not so long ago, people could not be diagnosed with both. It is actually they tend to go hand in hand. And also, people who are diagnosed with ADHD also demonstrate strong autistic traits. Autism affects social communication, sensory processing, routines, and interests. ADHD influences attention, energy levels, I can't read that, and impulse control. Oh, great, that's good. Thank you. And then when both are present, the traits of each condition can interact in ways that are complex, sometimes amplifying difficulties, sometimes balancing each other out. I would describe, well, I do describe being autistic with ADHD in that my autistic brain needs order, calmness. I need to feel in control, and I like my day to go according to plan. My ADHD part is highly creative, brilliant at problem solving, really interested in lots of things, and so it's like my head is full of bees. And then there comes a point when the two clash and I can't function anymore, and I end up having to crash out. One of the things I'll do is be under a weighted blanket on the sofa watching back-to-back Netflix or something like that, just to calm myself down, because it's exhausting. So it's the two conflicts that I live with, and that point of where ADHD meets autism, I think is particularly challenging for many people to manage. Have we lost them? Oh, okay. Bye. Judy, you know so much about this, and Sophie.
Yeah, I mean, and I think that, you know, I think you're doing a fantastic job, because clearly this morning, I think it's a really good example of how autism and ADHD interact. You know, you had an unusual and unsettling start to the day with the travel being unpredictable by the sound of it, and it's sometimes really hard to understand the impact of how hard that is to cope with and to manage. I mean, you know, it's for adults, but also for children, and I think that that's why sometimes, you know, schools and parents find it difficult to understand why their children sometimes need to be left in a quiet place when they come home from school, because they've been working really hard at, you know, keeping it all together and focusing on what they need to and not getting into trouble. Because as Kathy said, this rejection sensitive dysphoria, as it's called, this fear of getting things wrong, is often very strong in people who have both autism and ADHD, and the thought of getting things wrong is devastating. It's really hard to cope with, and a lot of people will try and hold this in when they're in front of other people, so at school and doing social things, but when they get home, they're completely burned out, completely exhausted. And, you know, any minor criticism is often really taken to heart. It's dwelled upon, it's thought about over and over again, it's brought back into your mind again, and, you know, that in itself can be exhausting. So it's not always what you see on the, you know, the external behavior. It's about thinking what's going on underneath the surface sometimes. Does that make sense?
So I see it as sort of this internal turmoil. You have sort of a path of autism going in one way and a path of ADHD sort of sometimes going in a completely opposite direction, and you're sort of trying to find a middle path that's inside yourself, and then you add on the outside world, those social communications that you're not quite sure about, maybe don't understand due to the, you know, social difficulties related to autism, the impulsivity related to ADHD, that internal spiral. You're so worried about trying to get the balance right that, yeah, you start spiraling, you start over focusing on the negatives, and then it's exhausting, that trying to marry the two paths.
Thanks, Sophie. And that sense of, or the dread of getting things wrong is huge. And so many people I work part-time as a psychotherapist, and the amount of times that clients have been told they're overthinking. And actually, it's not overthinking, it's just, something's going around in their head and they cannot resolve it because they don't know how to. And they need somebody to help them to process what's happened and say, actually, you're okay. Next one, thank you. So Judy and Sophie, we're on to common experiences of ADHD.
What I wanted to say, Kathy, was the fact that, you know, a lot of this is related to a female experience, and I don't like to gender things because there are exceptions, but a lot of females, you know, girls and women get missed because they don't tick the boxes, if you like, for the kind of stereotypical standard experience of ADHD. And, you know, I've had experience myself with my late son, who was autistic ADHD, and he was very different. He was a rule challenger. He was very impulsive. He didn't always follow the rules, and sometimes his impulsive behavior got him into trouble. So I think that, you know, and I presume that he felt guilty about it at times when things had gone wrong, but that wasn't always obvious immediately, because there could quite often be the same behavior repeated almost immediately afterwards. So I think it's important to point out that it's a spectrum like everything else, and some young people will be more impulsive, they'll be more obvious, and they're often the young people who get spotted quite quickly in school, because they're the ones that shout out, turn the chairs over, run out of the classroom, can't sit still. Whereas others are more internalizers. They keep a lot of it to themselves inside, and it's not seen straight away at school, which I think is the challenge sometimes for when people want support and a diagnosis, because people hear the word ADHD and assume that it's going to be a hyperactive little boy running and jumping on the sofa, which it isn't always. But the common experiences are there, I think, for both types of experience, I think.
So the common experiences can be intense focus and energy swings. So that can be being very active and very busy, and then being completely depleted of energy. He's sometimes easily distracted. Includes executive functioning differences, which are challenges with planning, organisation and time management. One of the factors about time is very often I can't say whether something happened a week ago or 6 weeks ago or 6 months ago. My concept of time is not accurate. And so that's also a common experience for lots of people who are autistic with ADHD. Social experiences. In the diagnostic manual, autism is described as a deficit in social communication. And actually, I sort of argue that we're not a bunch of deficits. We have different ways of communication, and actually what we require is clear communication. So if someone says to me they're going to do something by tomorrow, do it, or let me know why it's not happening. It's those sorts of things. Or sending an email to somebody and they don't bother to reply. Most autistic people would want someone to come back and say, sorry, I can help you, or sorry, I can't help you. Just need to know. And sensory differences. Both conditions can heighten sensitivity to sounds, textures, or environments. More than that, it can be smells, it can be temperature. the three of us could do a whole day on sensory experiences because they're huge, and we're not going to cover them today. And importantly, masking and burnout. This happens because people are working hard to fit in socially or to manage expectations, which can be exhausting. Before we move on to avoidant restrictive food intake disorder, Judy and Sophie, do you have anything you want to add?
It would be really helpful if anybody's got any questions or this, you know, this is a bit of a whistle stop tour of various different kind of conditions. Is you know, at this point, is there anything anybody would like to ask? Is there anything that's kind of a burning question?
Thank you. I'm not sure if it's a question or a statement. Just to go back to sensory experiences, my experience of trying to get an autism diagnosis, which I didn't get a few years ago, during that, the person assessing me said they just didn't take into account sensory experiences or differences in the assessment process. So given that you just said that you could spend a whole day talking about it, I'd like to talk about it a little bit at some point, because I don't understand how they can leave such a massive experience out of the assessment process. I am actually on the waiting list for another one in a different county, and they were the people who gave me my ADHD diagnosis, and they were really amazing. So I'm hopeful that second time lucky, but yeah, just wanted to highlight that sensory difference thing. Also with my children, it's just a massive, massive part of their experience as well.
How long ago that was? Because actually to exclude sensory experiences is completely wrong, because the DSM, I think we're going to be talking about this in a little while, but the DSM-5, which is, and the ICD-10, which are like, if you like, the Bibles for diagnosis, they have a list of criteria that need to be met, and sensory experiences are in there as one of the areas that counts towards a diagnosis now. So they should not be sort of excluded or discounted in any way, because I think that since the new version of the book came out, it's been realised just how much sensory experiences impact on autistic people and ADHD. So, you know, I would definitely challenge that, because it is part of the criteria now, and it should be explored fully in any diagnostic assessment.
I think it was pre-pandemic. I think it was 2019 or 2018, not sure.
And unfortunately, the quality of autism and ADHD assessments varies hugely across the country. It depends on the expertise and the training of the person that's doing it. And it sounds like you were unlucky, and hopefully next time you'll get somebody who will actually take that on board and listen to what you've got to say about it.
I'd add to that. You know, locally, I live in Cardigan, and one of my neighbours sort of knocked on my door one day and said, "I think I'm autistic." And I'm thinking, yeah, you probably are. So, and they're in their 60s, and they went for an autism diagnostic assessment. They ticked every box for being autistic, and yet the person assessing them said, "You can't be autistic because you have empathy." So, right, it's not. Judy, perhaps we need to talk about autism and empathy.
What now? We can do. Yeah,
Probably
I mean,
just to satisfy people.
It's part of a very big picture in terms of how our understanding of autism and ADHD has grown over the last, certainly over the last 10 years. You know, I've been doing autism assessment and diagnosis for 25 years, and the criteria for getting an autism diagnosis has changed dramatically. So in that time, it was very much a case of, it was only something that impacted on boys, and there was a very kind of stereotypical view, a bit like Rain Man, a bit like, you know, the train spotter who's got an obsession with trains and lines up their cars and flaps when they're excited, and doesn't make eye contact and is seen as lacking in empathy. That's an old-fashioned view. Now we realise actually that the majority of autistic people are hyper empathic. They feel things very, very deeply and very acutely at times. You know, some autistic people are comfortable making eye contact. Some people are not. Some autistic people have a group of friends. Some prefer not to have many friends and to be quite solitary. It's a spectrum, but I've heard many times when people have gone for an autism assessment and someone said, well, you can't be autistic because you're married, you've got a job, or you've got friends, or the person made eye contact when they're in the clinic. These are the stereotypes that need to be challenged, because the understanding of autism as a spectrum has moved on dramatically, but unfortunately some clinical teams haven't kept up with the new research, unfortunately, which is a detriment to people, isn't it?
Yeah, I mean, I see it as less of a lack of empathy and more a problem with empathy. So I personally, if someone else is upset, almost feel and try to take on their negative emotions, which is, you know, negative towards me. I struggle to understand maybe their mentality or their situation, but I certainly hyper empathize. I just don't really know what to do about it. So I see it more as a problem with empathy rather than a lack of empathy, but that relates to the social communication differences.
Thank you both. One of the aspects of empathy is it's what Damien Milton calls the double empathy problem, where autistic people or autistic people with ADHD will go a long way to try and understand neurotypical people, and yet that's not reciprocated. So we are labelled as the problem when actually it's a miscommunication between two people or two parties. Okay, that's fine.
Sorry, online question. I struggle with being able to give good timelines myself, and has got me in big trouble with my kids. Can I improve this?
I don't know. That's the answer. If there is a solution, please tell me.
Yeah, I think some, you know, obviously the obvious things like making lists and having visual reminders of things might help, but I mean, this is the issue often, that you don't just have one neurodivergent person in a family. You've usually got a whole family of them, and families are trying to negotiate their own difficulties and challenges at the same time as supporting their children's challenges and difficulties. And it's really about finding a way that works for each individual family. I don't think there is a right way of parenting, a right way of doing it right. And I think a lot of parents get blamed for having a different parenting style. But actually what they've done is adapt their parenting style to meet their own needs and also the needs of their children, and often their partners as well. So, yeah.
Thanks, Judy. So we're going to move on to avoidant restrictive food intake disorder. It's abbreviated as ARFID. And it's an eating disorder or disordered eating, where someone limits their overall food intake and avoids certain foods or both. So children with ARFID often control their food to help them manage complicated feelings and situations. However, whereas many eating disorders are related to weight, body shape, body image and self-esteem, ARFID is generally related to a child's anxiety about food and eating. And this can look like a child or young person or an adult sticking to foods that are the same colour. The texture of food is really important. It might be having a very, very limited diet. And it could be eating the same thing every day until they get bored and then move on to something else. I recall a mother who was a carer of their adult son saying they filled the freezer with food that they were eating and then they got fed up with it. So it happens. Why we're bringing this in and talking about it today is because ARFID can often be misdiagnosed, particularly in women and girls, as anorexia nervosa, and it's not. Another aspect of ARFID is that can be the fear of choking. So somebody I assessed locally a few years ago had choked on something, thought they were going to die, and then they were eating very soft sort of rice and pulses, and they were vegan. That's what they were eating, and it wasn't a very balanced nutritional diet, but they were so terrified of choking again, which probably most of us, if we've choked, can relate to that. That it becomes a really intense fear. Can we move on? So I've done it. So there are 3 subtypes of ARFID, and if you look online, there's some really good research about ARFID. So the 3 types are sensory differences triggered by certain foods, textures, tastes, smells, or temperatures. So somebody might really like cold, creamy ice cream, not hot food. Also, it's about not recognizing when they're hungry, not enjoying eating, or finding it an effort to eat. One of the things in relation to our sensory needs is it's what's called our interoception. It's the dashboard of our body. It tells us when we're too hot, too cold, hungry, thirsty, when we need to go to the loo, all those things. So it gauges those, and sometimes it doesn't gauge when we're hungry. So we can go on for a long time not realizing we need to eat. I'd say for myself, I don't have avoidant restrictive food intake disorder. However, it might get to the middle of the afternoon. I've been really hyper focused on my work and I think I haven't eaten or haven't drunk anything. It happens. And a third point is anxiety around eating, possibly caused by traumatic experience such as being sick or nearly choking.
It's worth saying, and Kathy did mention it a little bit, but I think ARFID is distinct from, general differences or preferences in food. I certainly go through phases of food. So, eating crunchy nut every day and then suddenly after 3 months never touching it again. That's not ARFID. That's sort of me finding a comfort food that I move on from, just as maybe I think not noticing when you've missed lunch. Again, that can be explained by other things, not just ARFID. It is, distinct, I think.
I mean, I suppose the other thing to think about is the importance of understanding the difference between this and, as Kathy says, a more kind of well-known kind of type of eating disorder, because it does highlight the fact that a diagnosis and an understanding of a person is so important, because I have worked in hospitals where there are young people who were undiagnosed autistic, and it was assumed that they had anorexia nervosa, when actually it was ARFID. And the treatment for someone with ARFID is completely different to what you might want to do with a young person who has anorexia nervosa. And to get those kind of treatments wrong can be very traumatic, particularly if the young person is not eating because of a sensory preference. And when I first heard someone talk about ARFID, some of it was around the disgust and the lack of enjoyment of certain textures. And this particular clinician described it as if I asked you to eat a bull's eyeball. If you think of these challenges and things they have on, is it I'm a Celebrity or something, where they're in the jungle and they're given these gross kind of challenges that makes them feel horrible. This lady was saying that for someone with ARFID, being forced or made to eat certain things would feel just as disgusting and horrible to them as, you know, it would if you asked someone to eat something really disgusting like a grub or a worm or something like that. So it's very important to treat it. And if anybody is impacted by eating challenges, there are a number of good resources on ARFID, and also there's something called the PEACE program, PEACE, which is an eating disorders program which has been developed specifically for autistic people. So you can get information about that online. They developed quite a good program with lots of supportive material if anybody's struggling with that.
Thank you both. Sorry. I'll have to ask Judy.
What's that?
Is ARFID directly related to being autistic, or can somebody have ARFID without being autistic or ADHD?
The evidence is mixed. I think, yes, I have come across cases of, you know, lots of young people, lots of children will have avoidant behaviours. Lots of children prefer to eat beige food, and they're not all autistic. It does seem to be somewhat more common in autistic people than in the general population, but I don't think it's exclusive to autism. I think some people genuinely have issues with texture and taste. So I think most of us would be somewhere on that kind of scale. I mean, you know, I haven't got ARFID, but I couldn't eat mussels or shellfish because the thought makes me feel disgusted. So, but I haven't got ARFID. So I think it's on a spectrum of difficulty, but I think it is somewhat more common in autistic people. Yes.
Thanks, Judy. Judy, you've mentioned the program for autistic people, PEACE. How's it spell that?
It's all capital letters, PEACE, and it's run by clinicians, or it was developed by clinicians at University College London, and it's been demonstrated to be quite effective as a treatment, because the standard treatment for an eating disorder is particularly traumatic for somebody who's autistic, who's probably got sensory needs anyway. It's just not the right way to approach it.
Thanks, Judy. All right, yeah, we do. We've got online questions as well.
So the first one is, I work with an adult who has recently been diagnosed with autism. They almost certainly have ARFID, but do not meet criteria for eating disorders team as they're overweight. How can I help them? Weight management has been suggested, but it's not a weight problem, a food problem.
Okay. I would ask who is it actually causing distress to? Is it I mean, lots of people will have a restricted diet. I mean, I think that the eating disorders team would only have the capacity to become involved if someone was in danger, I suppose, of, you know, if they were seriously underweight, if their BMI was very low, or they were not eating enough, and their nutritional needs, you know, they were becoming unwell because of the lack of vitamins or whatever. That might be more of a reason to get it. I mean, who is it causing concern to? Is it concerning the adult involved, or is it concerning to those caring for that person?
We haven't got the answer there, but I think the other aspects of ARFID is that, and Judy, correct me if I'm wrong here, that some people won't know, they might eat a very limited diet, and stick to certain foods and be very overweight because they don't know, they're interoception, they don't know when they're full up. And so I've met people where there have been big concerns about their increase in weight, which can get to the point of dangerous.
Yeah, but that's, yeah, I guess that would probably need a specialist team to be able to manage that, because as you say, it's about interoception. It's about not necessarily knowing that when you're full. There are all sorts of emotional reasons for eating. It needs a full, what we would call a formulation, to actually think about what's going on for that person. And it might be that somebody in a normal eating disorders team might not have that sort of understanding of the interoceptive difficulties. There are also things like Prader-Willi syndrome, which is associated with autism, that leads to overeating, and they often have a very limited diet. So it's a hugely complex area, and not one that would be dealt with easily by a sort of a normal eating disorders team, I don't think.
I agree, Judy, and I think I'm aware of situations where an adult, their food needs to be restricted, and yet we can't do that from a sort of legal way unless it goes to the Court of Protection. So you have to get the Court of Protection's permission to deprive them of their liberty to eat the foods they want to eat. So it does get very complicated.
Yeah, and I do remember when I was working in the hospital, a case of a young woman who actually died while she was a patient in the hospital because she was so morbidly obese, because she didn't know when she was full and when, and she was constantly hungry and was quite challenging towards staff. So, like you say, it becomes a really tricky issue to deal with.
Thank you.
I have an update from the person.
Yeah.
They said it's the patient who's having the difficulties. They're only eating 2 types of food, neither with any nutritional value. They're very embarrassed about it, and their weight.
Oh, that again, that is, it needs specialist support, because the usual approach is something called graded exposure to different this is almost like a session in itself, because you would have to work on a particular program. So it's called a graded exposure, where they are gradually introduced to trying different types of food without any kind of judgment, without any kind of challenges over it. But it's a very slow process, and sometimes it can be just a case of having the food on the plate but not touching it, to taking a small bite, to gradually increasing, and it's a very slow program, and it needs sort of intensive support, really.
Thank you. If a child is experiencing ARFID, you may notice the following behaviours. It's just an indicator that it could be ARFID. Only eating a small range of foods, which might be similar in texture or colour. Sophie referred to beige foods. Some people, when they're feeling very, very overwhelmed, will stick to a food that is comfortable with them, and it might be they're all beige coloured. So eating less food than they need to stay healthy, or not putting on enough weight, not recognising if they are hungry or feeling full very quickly, avoiding meal times or social events where they can't access safe foods, and showing signs of anxiety when eating or eating and drinking very slowly. The removal of safe foods. I'm working with a mother at the moment where her son is autistic with pathological demand avoidance and avoidant restrictive food intake disorder. He's in a specialist placement. Well, it's supposed to be specialist, and they've removed his safe foods. And that's really important, that people have the food that they can go to sort of get that comfort, reassurance, feeling of safety and predictability. So with autistic children, and again adults, they are likely to experience sensory differences, heightened anxiety, and it might mean that certain flavours, textures or smells can be difficult to tolerate. So and neurodivergent children can also find it harder to pick up on sensory cues, such as realising when they're hungry. And they might have difficulty engaging in activities they aren't interested in, or be motivated by the social expectations and the rituals around food. And that can be a really huge demand for somebody to be expected to sit up at the table, eat a meal with other people, with all the different smells and the requirement of socially interacting. And there can be significant overlap with the eating patterns associated with ARPID. And this is a quote on masking. Masking is typically triggered when social demands exceed an autistic person's limits. But Judy and Sophie, we've moved on to missed or delayed autism and PDA diagnoses.
Have we? We're not seeing that at the moment. We're seeing the
Okay.
masking screen slide at the moment.
Okay. Okay. It's all right at this end. Is it all right at your end yet? Is it? Oh no. Okay. I'll go back and come back to this one.
That's it.
Okay.
Okay.
I don't know that I can't remember if we are or not. Let me have a
Yeah.
I
look.
addresses a little bit in mine, but we guess we can always ask questions at the end.
I was going to cover this when talking about sort of missed or delayed diagnoses, because that is a very big part of why it can be difficult to get the right support for somebody. So do we have slides about why timely? Do we move on to the next one? Because I'll talk about this as we go through this. If you could move on to the next slide, please.
This one's why timely diagnosis matters. The one after that is current assessment guidelines.
Can I have the previous one, please?
Yeah, you can. Why timely diagnosis matters.
Yeah, I'm not seeing that one.
Okay,
Sorry. No, next one.
Is it not changing at your
Okay.
end?
Yeah, maybe, yeah, okay. Right, yeah. With a diagnosis, it's becoming incredibly difficult for parents and families to get a timely diagnosis at the moment. And in England, we have something called Right to Choose, which is a government-backed initiative that allows parents to choose the provider that they want to go to if their home provider can't provide them with a diagnosis quickly enough. What's happened is that the system has become completely overwhelmed because the percentage of people looking for a diagnosis has gone up 400% since 2019. So services are just overwhelmed. And so what people are being asked to do at some level is kind of almost prioritise those who would benefit from an assessment soonest, and that's often those who are in crisis. But when Sophie talks about her own experiences, she's possibly somebody who may not have been picked up early because her difficulties didn't become more apparent until she started secondary school, which is very, very common. And also, Sophie, like many of the young people I've seen, was someone who tried her absolute hardest to hide her difficulties and to fit in and to not stand out from the other children at school. And this is incredibly common. And it sometimes leads to challenges getting a diagnosis, because the schools will often say, well, we're not seeing problems in school, so it must be a parenting issue, or it must be something going wrong at home. But what it actually is that young person working really, really hard all day at school to hold it in. And then as soon as they get home to their safe place, which is usually their home, the tiniest little frustration will trigger an outburst, a meltdown, and the person will become really upset. And it's often hard for parents to see where this has come from, but often it's that build-up of the whole day of trying to hide it all and keep it all together. And I wanted to just share this response to it. It was a lovely email I received the other day, and this was a little boy that we assessed in 2015. At the time he was 8. He had been turned down for a diagnosis before because he didn't quite fit the pattern. He was presenting more like the girls that we see. He's a quiet, very anxious little boy, he was at the time, and he'd been turned away for a diagnosis because he didn't quite fit the pattern that was expected. So this family came to see us, and we assessed him, and we saw beneath the mask. We looked at, we listened to his story, we listened to his mum's story and the things that she was reporting, and he got his diagnosis. And she sent me this message the other day. So he's just turned 18, and he's now taking his A-levels, has passed his driving test, has got a good group of friends. He's happy, he's got good mental health. And this lady was saying she's so happy, she's so grateful for the help that they had as a family, and the understanding that he was a child who was struggling despite the masking and parent blaming. And this is the reason why early intervention is so important, because you then you listen to the person, you assess their needs, you make sure that they are supported, and more importantly that they understand themselves and the family understand them. So that's why masking is an issue and why timely diagnosis matters. Can we move on to the next slide, please?
Yes. That's the current assessment guidelines. Is that the right one, Judy?
Yeah, yes. I need the assessment guidelines one if possible, please. I'm still stuck on the previous one at the moment.
Okay.
No. Not getting it. Kathy, just
Is
no,
it there?
Oh, is that the next one? Yeah.
The current assessment guidelines.
I need the current assessment guidelines one first, please.
Right.
Yes, it's that's it. Okay. These are the issues with why it can be so difficult to get the right kind of support. So every service that you go to should be assessing a child according to the NICE guidelines. And the NICE guidelines say that the assessment for autism or ADHD should start within 13 weeks of a referral to a specialist multidisciplinary team. And that means a team from a variety of different backgrounds. So you might have a speech therapist or an OT or a psychologist or a paediatrician, but there's a core team, and what you get is different people's perspectives, because when you're doing an autism assessment, you have to kind of think, well, is this a global learning difficulty? Is this a speech and language problem? So is it just that the child has speech and language difficulties? So it's a bit like a jigsaw puzzle. You're putting all the pieces together. And we work to, like I mentioned earlier, something called the DSM-5, which is the Diagnostic and Statistical Manual version 5, or the ICD-11, which is the European version. And the people are, when you're going through an assessment, you have to tick the boxes to say that the person has difficulties in all of the areas that are there, which has things like social reciprocity, relationships, non-verbal communication, rigid repetitive behaviours, sensory difficulties. So you have a manual, if you like, to work from. But the manual hasn't kept up with current understanding. So it means that some people still do get missed. Adults also have the right to be assessed and diagnosed as well. But if you could move on to the next slide. This is the ideal situation. It would be wonderful if everybody was able to do that. But the reality is it's not happening. So if you could put the next slide on, please. Yeah.
Okay, so yeah, it's there, Judy. Can you see it or not?
No.
No. Okay. I'll go.
There we go. That's it. Yeah.
Okay.
NHS teams are overwhelmed. There are not enough specialist clinicians trained and able to assess for autism and ADHD. There's also reported to be insufficient funding to meet the growing need for assessments. And I don't know, do you have right to choose in Wales? I'm not sure that you do. I'm not sure. I'm not sure whether it's just you don't.
No.
Well, it was set up as an initiative to offer parents choice if they couldn't get an assessment with their local team. But all that happened is that they've transferred the waitlist over to a number of providers who are also overwhelmed. For example, we have a contract in Norfolk and Waveney, which is in the east of England. We opened our doors to referrals in November last year. By the following March, we'd received 2,500 referrals, which completely overwhelmed our team because we don't believe that you can do this quickly. You have to give parents time to tell their story. You have to listen to the young person's perspective. You have to do the job properly. If you're trying to rush it, you might miss something important. You might miss something that is relevant, but you're not picking up. So what it's meant is that there's families out there who are left in crisis with little or no support. And even getting a diagnosis doesn't sadly lead to guaranteed levels of support. Can you move to the next one, please? There should be one. There we go. Yeah. These are the figures that I find. In the UK as a whole, there's been a 306% increase in the number of children waiting for autism assessments. So there were 236,225 people waiting for an autism assessment and 668,000 for an ADHD assessment. And the wait times have gone way beyond 13 weeks. And some areas are now quoting well over 10 years to wait for an ADHD assessment. And for an autism assessment, waits can be up to 7 years. And this was the case in the area where I live and work. And what it meant was that children were being spotted as having some challenges, perhaps in year 6, the last year of primary school, and were not getting an assessment until they were about to leave secondary school. So all of that time was lost in terms of being able to provide them with the support that they need. And I don't know that there is an easy answer to this, because you can go down the sort of, let's see a lot of people very quickly and just put them through the system really quickly. But is that fair on the families? And is it likely to lead to either underdiagnosis or overdiagnosis? You know, if you're just doing it really quickly, you could be tempted to give a diagnosis based on fairly limited evidence. But on the other hand, you could completely miss the masking child, the child that's trying to sort of hide it at school. You could miss the young person who may be fine at 8, but by 13 or 14 is going to be suffering from significant mental health challenges. It's a really difficult situation. And what's also happening, I was part of a meeting yesterday looking at was it yesterday, Kathy? We were both there about fabricated and induced illness. Yeah, the number of parents that are now getting the parent blame has risen dramatically and has led to a huge increase in the number of parents that are being blamed because they're trying to find support for their children. They're going to various different professionals trying to get support, and this is flagged up as a potential case of fabricated and induced illness, which is again a whole other story in itself. But I think it highlights the challenges that many families are facing at the moment.
Yeah, and
Can we move on to the
there
next?
could
Sorry, yeah.
be an argument about why have a diagnosis, and yet it's really important for although services shouldn't be because of diagnosis, children, young people don't get the right education support if they don't have a diagnosis, if they don't have multiple assessments. And also, having a diagnosis, I found, for me, it makes sense of who I am. So it's been really important to have that. It's not merely about sticking labels on people, is it, Judy or Sophie?
No, it's not about label, and you know there are some. I've it's become a hot topic in Parliament at the moment, and there are a number of MPs in the UK, in the England Parliament, who are advocating for better SEND support, for better diagnosis, and then there are other politicians from other parties who are saying that there's a massive overdiagnosis and parents are just wanting a label for their children, and because it's become fashionable to have one, which is not the. I mean, nobody actually knows why the numbers have gone up so dramatically. It could be that we're just getting better at identifying it, or there could be something environmental that has gone on that has led to more young people and more adults experiencing the challenges that are associated with neurodivergence. I don't know.
Thank you. Is it time for us to take a break? Okay. How long are we going to have a break for? Okay. Judy and Sophie, we're going to have a 15-minute break. And it's 11:25, just before now.
Okay.
So you're just before 22.
Okay.
Can we come back? Because otherwise we're going to run out of time. Yeah. Can we come back to the group, please? Yeah. Judy and Sophie, the slide I've got up is autism, PDA and perplexing presentations. Is that the one you've got?
Yeah. Yeah.
Okay.
I mean, Kathy, before we could, were there any questions from the previous little bit that people have got questions about or anything?
Has anyone got any questions from before?
Hi. Hello. When you consider at the beginning you talked about rejection, would you agree that that rejection can sometimes, the feeling of it comes from obviously maybe a lack of a caregiver, lack of a sort of loving figure in the family, and they obviously can have that from a young age, or obviously, you know, sometimes it just gets passed on through the family?
Did you hear that, you two?
Yeah, I can. Yeah, I mean, this is, I think this is the reason for need. I mean, coming back to what I was saying about teams assessing for autism and ADHD, you need professionals who can explore some of these things. You need professionals who can explore the family dynamics, can explore what's going on within that child or that young person's life at the same time. You know, behavior is a form of communication and it can have multiple different causes. So yes, you know, you can get children who experience that kind of rejection sort of sensitivity. You can get children who display autistic type features, ADHD type features, who have got a different reason for the way those behaviors present. And that's it's again, it's a big area, and it takes many years to sort of learn how to unpick all these differences, which is again what worries me about the idea of a quick fix, and that you can just push children and young people through a quick assessment process, because it really doesn't allow the clinicians the time to explore all of the other factors that might be impacting. Does that make sense?
Thanks, Judy. So we're looking at autism, PDA and perplexing presentations.
I mean, again, going into what PDA is or isn't would take up a session on its own. It's a hugely controversial area. I've been working in this area for a long time, so has Kathy. Sophie has a diagnosis of a PDA profile, so we get it. We agree that it is something. It isn't always easy to pick up because children with this profile don't always present in a textbook way. There is debate about whether children with a PDA profile are even autistic or ADHD, or whether it is something that exists as a personality trait. The debate goes on. But what tends to happen when you have a child that doesn't present in a textbook manner, I mean, some autistic children, as soon as they come into our clinic, you can tell straight away that they are autistic, and it's often a surprise that nobody's picked it up before. Others are less obvious. And a lot of children and young people and adults don't always easily fit into the diagnostic criteria that we have to use. And these children are often deemed as complex or perplexing. And what happens is that families get passed from professional to professional, from team to team, with nobody able to give them a clear answer. Did you want to add anything to that, Kathy or Sophie?
That's fine. I'm just going to move on to the next slide. Oh, it's not working. There's some questions here.
So I've got 2 children, and I did all the parenting classes where you're supposed to do the sticker charts and everything. And my first child responds really well to sticker charts, and my second child just fell on the floor. And it's really interesting how that then it gets put back on you as a parent for not doing sticker charts properly, when maybe we're looking at different ways that child can be motivated.
Absolutely, 100%. Yeah. And this is why it is so important to have an awareness that some children don't respond in that way. And, you know, I mean, Sophie can probably talk about sticky charts. I think she would have sabotaged it or found a way of avoiding doing it, wouldn't you, Sophie?
Yeah, I mean, my mum was sent on parenting courses with me, and you know, they obviously applied to other kids, my other siblings as well. And sticker charts, yeah, I remember violently hating the sticker charts, and they worked for my other siblings, but it was this arbitrary barrier to improving because I couldn't control my meltdowns, which is what the sticker charts seem to be trying to deal with. On top of that inability to control a physiological reaction, I then had the stress of every time I don't do well, I don't get a sticker. And if I don't get a sticker, that means I'm letting the entire family down, and I have to get this sticker, which means I have to control something I can't control. So it sort of pushed this whole, I guess, implosion, this distress back onto me, whilst adding the demand of you need to get a sticker that you don't really want, otherwise it's not. So sticker charts were horrible for me. They worked for my other siblings and they didn't work for me. But my other siblings don't have PDA. So I think this demand avoidance, atypical coping strategies. But that's the problem with the recommendations that people get in these parenting courses. I feel like I didn't explain that very well. So I'm going to let Julie take over.
No, you did. It was perfect. I mean, I mean, this comes back to the need to identify what PDA is or what it isn't, to understand that all children are demand avoidant at some point, because that's part of being a child, you know, and every human in the world avoids demands at some point. You know, we don't do things we don't want to do, or we put off doing things we don't fancy doing. And there can be lots of reasons for that. You know, it might be an autistic child might be demand avoidant in the classroom because they don't understand the instruction, or because they are overwhelmed by sensory experiences. So they'll avoid going into assembly, or they'll avoid going into the classroom. That is, you know, they may avoid putting their shoes on or getting their coat on because of sensory reasons. And that is the kind of thing that most people understand. The avoidance in someone with a PDA profile is at a different level. It's a different, because it can be that the person avoids things that they actually want and need to do. You know, Sophie will explain about, you know, sometimes she will resist going to the toilet because it's a demand that is out of her control. So PDA may be an overwhelming need for control or a need for autonomy. There is also the issue that a lot of children with a PDA profile don't really understand or get the idea of hierarchy, the fact that someone can tell you, so that a parent can tell you what to do, or that a teacher can tell you what to do, or that anybody in authority can tell you what to do. So they end up being labelled as very naughty children or as oppositional. But quite often it's because they don't get it. And when a child says, "You're not the boss of me," or "You can't tell me what to do," that's what they genuinely believe. They're not being naughty. So there's a lot of research needed into what exactly it is. And I would love to be able to bottle what the essence of a PDA profile is. It would be wonderful if I could just say it is this one thing. All I know is that when you see it again and again, someone comes into our clinic and it's like, ah, there they are again. That's the same presentation. So it must be something. But there is a lot of work needed to identify exactly what it is. But what it means at the moment is that parents are sent on parenting courses. Parents are blamed for adopting like low demand lifestyles or picking their battles, which is what someone like me would recommend that they do. Because, you know, people have to function within a family. Their family life has to work. And the same thing won't be right for everybody's family. You know, some families are different. You know, sometimes having that battle about whether the child sits at the dinner table and eats with the family is a battle too far. You know, sometimes the child will need to go out in public in a pair of pajamas because they won't go out at all otherwise. It's about picking battles. And I think it's very easy to start judging people's parenting. You know, if you see a child out in their pajamas and trainers with no socks and unbrushed hair, you're immediately going to think that that child's neglected or that the parents haven't imposed sufficient boundaries. It's not as straightforward as that. And again, awareness needs to be raised about the different parenting styles that are needed, I think.
And I think when Julie says, you know, picking your battles, this is something that I personally now do myself. But it won't be a battle of sort of two equals. It might be sort of slightly absurd battles. So, for example, the child needs to go to the GP, but they won't go to the GP unless they go in their pajamas. At which point, is it more important when they get dressed or go to the GP? And if they can be forced to get dressed and go to the GP, will that then have any point, or will they just have a meltdown at the GP? So when it's picking your battles, it's picking your battles according to the child's needs rather than your own needs. Yeah, no, sticker charts were not fun for someone with PDA. No.
I was just going to say that my child had a really difficult path to diagnosis. And yeah, they were the child in the pajamas with the unbrushed hair and all of those things. And we went through the process and they tried to diagnose an attachment problem, i.e. attachment disorder, rather than autism. And I think maybe this answers or relates to the question the guy asked about reasons for various presentations, and what you then said about presentations of autism and something like attachment disorder being similar. Are you going to talk at all about the way that you can kind of differentially diagnose between those? Because that was really important to me, the understanding that there was a way to tell the difference between autism and attachment disorder.
Yeah, I mean, yes, I don't think that will be time to discuss it thoroughly, but there has been work that has taken place in terms of differentiating between attachment disorder and autism, and that's something called the Coventry Grid, which is, I think it was updated in 2015 or something, but that was something that I was part of 20 years ago now, where a group of clinicians worked on what made it, you know, what was different, and it's literally, it's there laid out in a table, so you can see what the different types of behaviours are. There is also something called the Coventry Grid interview, which again I think is a freely available downloadable resource that again will allow a tick box so that clinicians working through can tick the different boxes and you can get a picture of what's going on. And myself and my colleague Ellen a few years ago did something called the Coventry Grid interview modified with the PDA profile. Again, if anybody wants to go onto our website, our Help for Psychology website, which I'm sure I can put in the chat, that Coventry Grid interview with the PDA profile is freely available online if you want to download it. And it might help sometimes if that was to be taken into a diagnostic assessment, because a lot of clinical teams might not necessarily have had the experience of dealing with the difference between the two. So it is possible to distinguish, and the behaviours are different. But I don't think there's time to go through it fully today, is there, Kathy?
No, but you're right.
No.
The Coventry Grid is really, really useful just to look at the two.
Yeah. You can put the Help for Psychology website at them. If you go on to resources or journal articles, it's all there. It's freely available and downloadable from that site.
Okay, sorry, I just wanted to say that we run the parenting workshops, and they have developed more to be in line with, as diagnoses have changed and how we become more aware of what needs to be in those courses to be supported. So we have developed new initiatives. We do family links. We do very nurturing parenting workshops. So I just wanted to say that, as with everything, those have developed too. And obviously, if anybody wanted to talk through any of our workshops that we do run, we do an ADHD one and we do an ASD one. And I think some people in this group have been on those courses, and I'd like to think they are beneficial, but the girls would never we would always say pick your battles. So I just wanted to put that out there, that parenting workshops are, and you should never be sent on one. You should always want to come. So if anybody feels they've been sent on them, then we would be happy to do a one-to-one profiling for you, or just sort of benefit whatever you need, really. So.
And I think it's important as well for parents and professionals in groups like you're talking about to challenge this idea of attachment disorder, because actually the criteria for reactive attachment disorder means that the child should have experienced significant and long-term disruption in their primary caregiver. So, and then the vast majority of the children with a PDA profile will have very attached parents, but very, very caring parents who are trying their absolute best. So I think it's important sometimes to challenge that and say, where is your evidence for a reactive attachment disorder? Because it's one of those labels that sticks, and it shouldn't be given in for a child that's got autism and a PDA profile. It's not fair, and it's not appropriate.
Yeah, Judy, my experience, I'm a social worker, and I've seen so many assessments by social workers where they're saying this child has an attachment disorder when the child is autistic with PDA or a PDA profile. And so it ends up becoming parent blame, and it's about the parenting approach. And my view is that I'm not qualified to diagnose an attachment disorder, so why should any social worker do that?
And it's sad that when parents are really struggling, and that they might reach out to their social care team to ask for support and help, it gets turned on the parents, and it becomes a parent blaming exercise without people fully understanding what's going on.
I just wanted to kind of add to what the lady at the back said, that in Ceredigion, it's very strange, okay. In Ceredigion, the parenting and families support team are really amazing. They do these really great parent courses for autism and ADHD, and I think that there is people can join those if you've just got you've been referred for a diagnosis. You don't have to have the diagnosis, so that support can come in really early on for parents. And there's also a little group of us professionals in the county who, a lot of us have got neurodivergent family members who are really kind of focused on how we can provide really good support for families with a child with a PDA profile.
Thank you.
I wish every area did that, because that's what's needed.
Right, Judy, we're moving on to the next slide. So again, it's a continuation of autism, PDA and perplexing presentations. Have you got the slide up? Is it there?
Yeah, I mean, it's again, it's another one of those things where both boys and girls can mask. I think that there is a definite difference. Some are what we would call externalizers, and they are the young people who are picked up very, very quickly because they demonstrate their challenges and their difficulties quite vocally and quite early on in their life. There are some young people, I think Sophie would include herself in that, where actually it's all kind of sucked inside, it's internalized, it's not shown as much on the outside. And these can be the ones that the young people who struggle to get a diagnosis. If you've got a child in the classroom who's refusing to do anything, who is throwing the furniture around or hitting out at people, they're picked up very, very quickly. The child who sits in the classroom quietly and sucks it all up and tries to comply while they're in school and then has the most almighty meltdown at home, those are the ones that it may be more difficult to get diagnosed quickly and accurately. And it's, you know, it unfortunately it's still not very well understood, and it is possible that people will get delayed or misdiagnosis despite there being very early signs of it. And actually, in my experience, you can usually pick up the signs quite early on in life. You know, even very small pre-verbal children can express their demand avoidance, and it's more than the typical 2-year-old development, but it's there.
I mean, one of the ways that I tend to assess children and young people who appear to be fine in school is to go and observe them in school, observe them in break times, the unstructured times, to see how they cope with the social interactions, and also to be at home when they arrive home from school. So, and they know that I'm going to be there, and observe them at home. And so you're sort of seeing both sides and tying the two up, which is how I think a good assessment needs to happen.
Yeah. I mean, the only thing I would say to any parents who are going forward with a diagnosis is I don't personally feel happy when people bring me videos of their children having a meltdown. You know, I think that's unfair on the child, because none of us would like to be recorded when we're in that kind of distress. You know, if someone says to me that the child has a meltdown when they get home from school, I kind of believe them. They don't need to show me evidence.
Yeah, I agree, Judy. Okay. Can you move on to the next one? Okay. So, Judy, this is about the post-diagnostic support gaps.
Yeah. I mean, that comes back to, you know, you've not only got a delay in getting a diagnosis. When people have a diagnosis, I think sometimes they can be disappointed by the lack of support. And the groups that the lady that was talking about are fantastic. They are really helpful, and hopefully by parents feeling supported, and even whether they got a diagnosis or not, it will avoid some of the more serious problems. I think that the biggest concern is when you start to have more serious mental health challenges, and they're told, you know, the CAMS services are overwhelmed and they're told they're not serious enough, which is awful. I mean, in Norfolk, unless a child is actually standing on a bridge threatening to jump off, that's considered serious. The kind of run up to that they may struggle to get seen in a timely way because of the huge wait times again. And then it's often difficult to get support for a young person in school. I mean, with a PDA child, I think the not fine in school report said that something like 70% of children with that profile are not regularly in school. And it's quite worrying because obviously the new Children's Commissioner, they're looking to clamp down on children's attendance rates at school, and parents are at risk of being fined or get into serious trouble if their child's not in school or in an education setting of any kind. So again, it's another kind of crisis. You have the diagnosis, the support, and the send battle as well, trying to get support for young people in school, and all of this lack of support leads to more problems. And I always think a stitch in time saves 9. If only the authorities would put that money into early support, early intervention, you might save some of the problems later, and there wouldn't be so many young people who are in crisis or families that are in crisis.
Yeah, I mean, I personally, my attendance was nearly perfect up until I went into hospital, and then I never really returned. And actually, I think if there have been some fundamental differences in the way my schooling experience was and the way my autism was considered, and especially the PDA, it might not have led to such a dramatic no attendance. I mean, it was like 7% in year 11. Yeah, that just really shows the importance of early support and maintainable support.
What were
The traits, sorry.
Yeah, what would those fundamental changes have been for you? Because I think that's where I struggle, is that everybody's so different with what they need.
Yeah, so I think for me, a lot of my anxiety is related to perfectionism, and making sure I had done not only the bare minimum, but everything to the best of my ability, which was exhausting. I think if I had had some basic understanding of the fact that actually it wasn't necessary to be perfect, and that not all my peers are trying to be perfect, so why should I? Also, homework. If I reduce the stress of homework, reduce the ambiguity around homework, I wouldn't have had to sometimes do 2 homeworks and then decide which one to hand in. So I managed my communication and social problems and my PDA challenges myself by doing more than I could. So I think if that had been monitored and realised that my grades and my attendance did not reflect how I was coping, and actually assess how many hours of work are you doing, how is your mental health, are you stressed about it, are you relaxed about it, and if that had been picked up and managed and dealt with my autism and PDA considered, I think I could have made some adjustments earlier on, which would have allowed me to continue maybe attending education.
Yeah, I think there is also the issue of burnout as well, the autistic burnout, because I think that some young people, the strain of trying to fit in and to do what's expected of them leads to almost like a complete collapse. And I think we're getting better at understanding the mind-body link, because a lot of these young people will have physical symptoms alongside their, they will experience pain, they will experience repeated infections, they will genuinely not be well sometimes, or they won't be able to get out of bed, or they won't be able to function properly for a period of time. But I suppose what needs the support, parents need the support to support them during that period, but also to make sure that the support's in place so that they can go back to a normal life. Because what is really sad is the number of young people who are literally just stuck in their rooms for weeks, months on end, and they get stuck into a cycle, and it gets really difficult to move them on and to support them back into a more meaningful life for them, I suppose.
Thank you, Judy, and thank you, Sophie. Question.
Oh, hello. My daughter's 18. She was diagnosed really, really early on when she was like 3, 4 with being autistic, and which is okay. And she looked like an autistic child, pretends as an autistic child quite clearly. You know, you could see it easily. But as she got older, she started lashing out. And like really lashing out at people. She's 18. She's still doing it. It's not her fault. I understand that. And trying to get help, I asked 10 years ago, a decade ago, and trying to get that help. She's only just got it now in school. It's ridiculous. You're going to them saying, I need help. I need to help, because this child is a ticking time bomb. She's going to go out into the world if she is allowed to go out into the world, and if she can do that, you know, later on, and something's going to happen. We know something's going to happen, and they don't listen. They're not listening to us. And it's only now I've been asking for help for her to try and get her to recognize when she's getting angry, when she's, you know, when it's going to happen, different things in her body that might present to her that she might be able to understand when she's getting angry, and to try and get her to stop. I know it's an impossible task with these kids sometimes, but to stop and to try and at least just verbalize and say, say to her, I'm trying to get her to say, I'm upset, I'm stressed, something's going wrong, and she can't do that. And she just explodes. And it will be whoever's there gets grabbed or kicked or things thrown at them. People don't understand. In CAMS, it's taken me ages to get into CAMS. And they put her on Prozac. She's been on Prozac for about 7 years. And that's where we are. And nothing's changed. And now she's 18. Now she's out of CAMS now. And now she's got to try and access adult mental health. It's too much of a change. They should not desert kids who just magically turned 18. Nothing's changed in their brain because they've turned 18. And then you've got to try and navigate the adult system. It's ridiculous. They should stay in that system until they're 25 because they're classed and it's all wrong. Now you've got to try and tell your story to a whole new bunch of people who don't know that child. And it's just wrong. There is no continuity there. Where'd you go?
The NICE guidelines do recommend a transition plan, and it should be extended and tailored for specifically people with neurodevelopmental conditions like autism. I'm aware of that because it didn't happen for me. The system is horrendous. I think none of us three are saying that the system works. But yeah, I don't know what to recommend, but there should be a transition. If there's not, then that's wrong.
I think that we need, or as a nation, we need to fight for teams that support young people up to the age of 25. I think some areas do. I think Norfolk does. Their Children and Young People Service keeps them up until 25, because that, even that might not be perfect, but if you think that the majority of autistic young people are probably below their actual chronological age in terms of their emotional awareness and understanding, they may have significant challenges recognizing their own feelings or being able to explain them. So putting it forward to 25 seems to be better. The same with ADHD, because there is evidence that the brain, the frontal cortex, the frontal lobes of the brain start to mature more from about 25 to 30. So it makes sound scientific and practical sense to change the support system to go through to 25 and to make it accessible. Because I agree with the lady that just spoke, you know, the transition to adult mental health can be really tricky, because up until relatively recently, adult psychiatrists didn't even have training in autism and neurodevelopmental conditions. I think it's changing now. And I think this is what we're coming on to, is that once you are in adult services, you can have your autism diagnosis questioned, you can have people challenging what's going on and perhaps labelling it as something else, which I think is what we're going to go and talk about in a short while, aren't we, Kathy? Is that coming next?
Yes, it is, Judy.
Yeah.
Sorry. Oh,
Yeah.
Got a question?
Yeah. Question to Sophie. When I was watching you earlier, obviously answering that question about how you felt and how you had to get into hospital and so forth, the sort of word that came out, looking and sensing you, was just a complete overwhelmed. The system, and also you being so focused at getting everything so perfect that you'd created a sense of overwhelmed. And the thing is, the system isn't there really to support even a normal person, let alone yourself. So the system isn't working. Then the system, obviously the NHS, obviously I'm not blaming any, the people working within it are trying their best. But it's always the system. And the only system that's working now is us being here today to discuss it. And really, fundamentally, when you consider the schooling system in Finland, they don't actually allow children to go to school until they're about 7 or 8. And it just works better. And they actually have more funding left over for children and but also what I'm getting at is then there's been that sort of loving support, that nurturing support, even though I'm not trying to criticize anybody here or anything. It's as we were sort of meant to be. We're not meant to be in this sort of system the way it is. It's just too controlling and conforming.
Yeah, so I mean, I would agree with that. It was a complete overwhelmed, that time in my life, everything was overwhelming. And I think I was so focused on making sure I was perfect, which is impossible. I mean, it was then, it is now. And that, of course, is overwhelming because you worry about every single little thing. I think I went to a grammar school, which I enjoyed the learning. It was good academically for me, but the school was so focused on exams and results, and that, that's a common thing with the UK education system. You learn for exams, the whole point is results, the whole point is going to the next stage. And that sort of seemed to feed down into our student mentality of, if you're not getting the good grades, it's because you're not working hard enough. And there was a whole load of other things playing as well. But yeah, I mean, you picked up correctly. It was just a complete overwhelmed, and then suddenly it's sort of everything crashed. Should we move on to the next slides? And then I think that might be best, because I sort of go over that later. Yeah.
What I'm thinking, Sophie and Judy, is if we move on just to talk a little bit about personality disorder, and then for Sophie to have sufficient time, Sophie to have sufficient time to share, for you to share your experiences.
Yeah.
Yeah.
Whiz on then. It's fine.
Right, okay. So if you can move on to slides, I think it's 25 and 26. Carry on. Yeah.
Yeah, I think that's.
So,
that's it.
Yeah. Okay.
Yeah.
So I'm going to touch on this, and if anyone is interested in reading a lot about MIST and misdiagnosis, Judy, 2023 or 23, published a book which has got lots of experiences of MIST and misdiagnosis, including borderline or emotionally unstable personality disorder. And it's very difficult it's painful to read. I read it and it's very, very emotive, and it's people's real lived accounts of what they've been through. So borderline personality disorder, now renamed emotionally unstable personality disorder, it's an experience that many autistic people, particularly women, are likely to be misdiagnosed with a personality disorder, particularly when experiencing a mental health crisis. And what fails to happen is for not always, but very often, is psychiatrists don't necessarily understand the female presentation of autism, and so people get labelled as histrionic, attention-seeking, difficult, and it's one of the worst diagnoses to have, because I worked in the mental health team for a long time, 13 years, and it was if somebody was referred to the team with what was thought to be a personality disorder, nobody wanted to work with them. Well, I did, but on the whole, and that's a discrimination. It's a national thing. Anyway, this is supported by recent research. Can you move on to the next slide? So, and alarmingly, 3/4 of people diagnosed with a borderline or emotionally unstable personality disorder are female. And incidence of borderline or emotionally unstable personality disorder has increased with autistic participants. There's recent research, and I was part of this research team headed up by a woman called Dr. Liz O'Neill's, and discovered that autistic people are statistically much higher to be likely to be diagnosed with personality disorder. And yet, when I found this very ironic, when we submitted the paper to the Lancet Psychiatry, it was rejected. Probably because psychiatrists don't want to think they're wrong, but it hasn't gone there. So it's actually going to be published in Autism very shortly. But I found that sort of, it proves a point, really. I'm going to, rather than go through the next slides, I'm going to go on to Sophie, because I really want you to have your time to be able to say what you need to say, and also allow for people to ask questions at the end. So over to you. If you could go down to Sophie's story. There it is. Thank you. Oh, Sophie, you need to put your sound on.
Sorry, can we go to the next slide? Perfect. So we had a lot of changes at home. When I was around 9, we had an extension on our house, and I'd always had these massive sort of not quite tantrums, but we weren't sure what they were. They got a lot worse after the changes at home, which led to my parents taking me to the GP. And after some sessions, I was diagnosed with autism. I wasn't told about my autism. It was said to be borderline because it wasn't affecting school and social situations, mostly because I was masking at school. But I noticed the differences between myself and my peers, my siblings. I would still have these terrible, terrible meltdowns, which I blamed myself for. I thought it was my fault, that I was being bad and I should improve, rather than understanding that actually meltdowns and shutdowns are a part of autism. So as I internalized this sense that I was a terrible person, I masked more. It became unmanageable. It was like this complete split. At school, I was perfect. I was getting the grades. I was talking to people, doing loads of activities. And then I would go home and it was like I'd transformed into a completely different person. I wouldn't speak for weekends, or I would scream and shout to the extent that neighbours would come round wondering what was going on. So my parents were sent on a lot of parenting courses. None of the techniques seemed to work, things like sticker charts, as have already been mentioned, but also sort of leaving me to calm down, which then I felt very, very isolated and alone. A lot of disciplinary measures. Then at about 14, I experienced an autistic burnout, and I started engaging with the mental health services. So next slide, please. So my autistic presentation was, as you can probably guess, non-stereotypical. I didn't fit with the person who can't make eye contact or has no empathy or is only interested in talking about very specific stereotypical sort of male interests. This is because I have inattentive ADHD, which also wasn't picked up, a pathological demand avoidant profile. I'm high functioning, so my autism never affected my academic work. And also my being female and having sort of that classically female presentation meant that it was ignored. So when I then went into mental health services and inpatient units, professionals would question my diagnosis. So I have had, I think to date, 4 autism assessments, all of which have been people testing whether or not I am autistic. And that's even after the first one, when I received the diagnosis. Clinicians labelled me as oppositional instead of noticing signs of PDA, and they didn't build on my autism diagnosis to think autism, co-occurring conditions and mental health issues, plus burnout means maybe autism, PDA, and other comorbidities. They saw oppositional, extreme behaviour, which they put down to attention seeking and controllable, combined with parent blame. They weren't boundaried enough, they weren't structured enough, they weren't disciplining me, and sort of questioning their own mental health. So that led to my parents being blamed and questions of EUPD, even from below 18, when you actually cannot give an EUPD diagnosis from if you're under 18. So the next slide. Yeah. So there are 9, I think, DSM criteria traits for BPD or EUPD, and you only need 5 to get an EUPD diagnosis. I was never diagnosed, I think it's worth saying. I managed to avoid it with my parents and various professionals along the way fighting by my side, including Judy and Kathy. So I've put this together. It is the EUPD trait and then commentary on the other disorders which contain that trait. So I'm assuming you will be sent these slides at some point afterwards, but essentially, if you have any 2 conditions, say complex or normal PTSD, autism or ADHD or depression or bipolar, if you have any 2 comorbidities, and the rates are higher for comorbidities in autism, you then could technically have traits which can account to an EUPD diagnosis, which is massively problematic because of the treatment differences in EUPD as opposed to other mental health conditions. You go to the next slide, please. Emotionally unstable personality disorder. No worries. So EUPD treatment seems to be mostly centered around, I'm sure people have heard of DBT, dialectic behavioral therapy. And that's about working on changing the behaviors and taking responsibility for your own action, rather than addressing sort of fundamental communication issues in autism or mood problems like depression and thinking problems and misunderstanding of emotion. So I was given or prescribed the DBT treatment on various occasions. So the first time I completed the DBT program, I could answer all of the questions, but because I didn't understand it on an emotional level, I think because of my autism and alexithymic challenges, I couldn't apply it to myself. which meant I was blamed for not complying with the treatment and not complying with the fact that, well, basically I was blamed for the fact it didn't work. Yeah, and it didn't address any of my issues. It just turned the blame back onto me for my own mental health issues, fueling the depression, the idea that it is my fault, I am the problem, I am the bad one. But every single time I interacted with therapists who accounted for my autism and PDA, my mental health improved. Next slide, please. So I've done a lot of work on understanding autism, PDA, my ADHD, and how it affects me in everyday life, or my neurodivergence. Receiving the right support has allowed me to gain this understanding and work on the fundamental problems that I have, which have brought me out of a very deep and long-seated depression. The better I get, the less service support I need, the more independent I am, and the more able I am to cope individually. But when I do interact with professionals, the challenges aren't belittled, they aren't ignored. I'm not personally blamed for any of my problems. It is seen as a problem to fix and a way that I can move forward and live a better life, rather than I am doing it for attention. So the importance that this validation has given, let me start that again. So the impact of that validation has been life-changing for me. And that's what inspires me speaking today and sharing my story. Because by denying someone that basic understanding of themselves, you're stopping their recovery journey before it starts. And yeah, today I'm here and I'm doing a lot better. And yeah, I think there's a long way to go, but getting the right support has changed my life. That is it. Any questions?
I want to say that when I first met Sophie, she was in an inpatient unit and she was a very, very different person to the person you see today. And she spent many years stuck in the system without the right kind of support. And I'm incredibly proud of the person she's becoming, because honestly, I can't tell you how different she seems today compared to the young person I met in 2019, I think it was. Something like that.
2019, yeah.
Yeah. You were very, very heavily medicated. You were very poorly, very unwell. And, you know, it almost felt at some point as if the world had given up on you, because you were stuck there in the system. There was very little useful, helpful kind of community support that was offered to you outside of a hospital setting. And I think that you've done amazingly to be as resilient in where you are today. You know, it's amazing.
Judy, I completely agree with you. And what I remember as well is Sophie was, her mum was her primary carer, and yet she didn't get the support she needed either. So it was both of them not having the right support, both mother and daughter being misunderstood and blamed for the difficulties that occurred, rather than the support services thinking we're not understanding, we're getting things wrong. Sophie, you are so different, and you are to be celebrated for who you are and what you come through and what you survived.
No, it was a cycle of every time my mum asked for support, she would get blamed for all of my problems, and every time I accessed support, I would get blamed for all of my problems. So although we needed support, quite often there was just nowhere we could turn to that would listen and not, you know, threaten the worst, really, and make me and our situation worse. So it was really challenging, but I was lucky enough to have found enough good people along the way to get here.
Yeah, and I think it's fair to say, Sophie, that certain professionals probably saw your mum as difficult or as demanding, because she was great at advocating for you, but you know, I think that, you know, that is often the attitude of like teens, when they kind of close ranks and say, oh, this is just a difficult child with a difficult parent. And actually, the reason she was a difficult parent was because she was fighting as hard as she could to get you the support that you needed.
And to keep me alive.
Yeah.
You know, it really was that serious.
It was that, yeah.
Yeah.
Can I just ask, there's a couple of points really that have occurred to me during this session, and thank you all for your insights and your helping us understand better. The main thing that I've thought listening to Sophie was that the problem is all of us, in that we don't just accept people for who they are. And while support is absolutely essential, it starts with a sense of all of us being equal, none of us being more important than the other, and not being afraid, from a professional's point of view, not being afraid to say, I don't understand this, but I do want to help, and then look towards that. And the other thing that occurred early on, I'm not sure how correct this is, but I was just wondering, thinking in terms of an autism and ADHD comorbidity, it seems to me that PDA is straight in the middle of that Venn diagram. It seemed to explain it to me that if you are ADHD and autistic, and I think there are probably more people who do have those two occurring conditions, that PDA seems to be slap bang in the middle of that Venn diagram. Do you think
I would agree. Yeah.
I think
it's almost like the brains bumping up against, two brains are bumping against each other sometimes, I think.
Yeah, no, I think talking about, it's that inner turmoil, isn't it? But I think what Kathy said about a difference, not a deficit, is if that is more generally accepted, I think it will improve a lot of things in the services and just general society.
Thank you very much, Sophie, and I do feel for your mum, and I think it's certainly there's a group of us that need to be recognised because we're parents of older children who have not yet had a diagnosis. I'm talking about us having children in their 30s and 40s, and we are trying to support them as parents, but we're also trying to support grandchildren as well. And we're often a lost generation because we're blamed for so many things as baby boomers. But how do we support both our grown-up children who are waiting years for a diagnosis and our grandchildren who are going to wait just as long? Now, I do appreciate that in rural communities, we often don't have services that we can actually go to. But what would be really interesting from today is to know where we can access really robust information, because there's so much nonsense on the internet. We need to know where can we go to actually access the support for ourselves so that we can support our families.
It's actually what you're saying about being I'm probably of the same generation, and I'm currently supporting my mum, who is almost certainly undiagnosed autistic, and she's now 87 nearly. And, you know, I think it's this whole lifespan thing. You know, I've got grandchildren, children, and a parent, all of whom are somewhere on that spectrum, and all of who have different support needs that will change over time. You know.
Are there any resources that you're aware of which are actually really robust? I've put the link to the Help for Psychology resources in the chat. but is there anything else?
I mean, anything that is out there that is produced like professionally and peer reviewed, although as Kathy said, sometimes getting evidence and papers and things through peer review is quite difficult, and without that kind of validation of being published in a evidence-based journal, you're struggling a bit. But what I would say is I wish a lot of these TikTokers and Instagram people would just go away, because I honestly think it's fueling that thinking that everybody is autistic or everybody has ADHD, and that's not the case. And it takes away the struggles or the recognition of the struggles that some people are actually experiencing in their lives.
And also,
Yeah,
as Speed's highlighted, it's these struggles that parent carers have. And I see I'm a parent carer, and we're like a hidden army, quietly doing sometimes the impossible. No pay, no recognition, sort of treated as if we're less than because we asked for help. I sort of see the whole of the UK surviving because of parent carers who aren't paid to do what they do. Because if you got paid properly for everything that you did, we'd be bankrupt as a nation. There really does need to be that recognition and acknowledgement. So important.
Could I just ask a question about, Sophie said at one time she was heavily medicated, and I just wondered, coming from off the medication, I just wondered, with your therapy and all you had to endure, did you find one medication beneficial at all? And do you still have to take a medication now?
So I mean, my medication was absurd. I was on a ridiculous cocktail. I was taking over 30 tablets a day. Like, it was absurd. So at some points it was very, very hard to know what was doing what. I think, yeah, I mean, benzodiazepines were I'm off them now, and I'm incredibly grateful, because I couldn't function. I think risperidone was horrendous. I mean, I was put on antipsychotics and I'm not psychotic. Some antidepressants, I don't know how much difference they made. I'm still on some, but I can't say. The one which I think has helped has been the ADHD medication. That's not, I was put on that when I was 17. And I'm very, very glad that I managed to grow up as a child without ADHD medication, because I got to know my own brain and my own way of working, and understand myself really without the crutch of medication. But I know when my mental health started deteriorating, having that, that medication did help some of the restlessness. It wasn't a plaster, it wasn't a magic wand, but that helped a little bit. But in terms of other medications, I can't say what did what at which point. It was too much to know. But therapy is the one thing which I can without a doubt say has helped me. Therapy adjusted for autism, that's been the biggest help.
Sorry, I have an online question. Someone has asked, how do I help my 12-year-old PDA child who isn't able to engage with services as they're in burnout?
I would say acknowledge that and give them time, but try the small steps as they recover to start introducing activities and things again that they may enjoy. But there may be a period of time where they just need to be allowed to be and to recover. But that's a hard thing to fight for, because lots of people don't agree with it. So
Well, it's keeping all the demands off, isn't it, Judy? So that
Yeah, for a period of time. Yeah.
And I think having fun with challenging them as well, because I used to just comply and then explode, whereas now I will do little things which don't quite make sense to other people, but that I quite enjoy doing and make it able. So, for example, filling out a form, I might change the questions a little bit. I still answer the question, but I'm not filling out their form and, you know, manipulating the situation a little bit and having some fun with it. But you need experience and the motivation and the time to be able to do that.
I've got a sort of statement again, but in case anyone else hasn't spoken who has a question, I've already spoken. So is there anybody else? Okay. I really agree in some way with what was said before about online stuff, but I also have a counterpoint to that as a 45-year-old person who's neurodivergent, late diagnosed, and who has neurodivergent children. I also I had burnout at age 13, 14 and left school, then went to college, and I had a lot of social issues, a lot of bullying. And I'm aware that cyberbullying is awful, but one of the things that I've thought about, reflected on about being online when I'm older is that if I'd had resources online, the kind that I see, I wouldn't have thought that I was so alone and so weird. And I really benefit from seeing some stuff online that is actually good quality. And it also normalizes some stuff that, you know, in the past, before I had a diagnosis, I thought were failings that I had that were personal failings and not, you know, things that people commonly struggle with. And so I just wanted to say that it's not all bad, the stuff online.
I agree. And I think that one of the things that, well, I would always say to anybody is find your tribe. Find other people out there that get you. Because if you get a room full of autistic people or ADHD people, they communicate perfectly fine with each other. They get each other. They, you know, I think that's half of the issue. It's about finding your tribe. It's about finding people that you can relate to. I wasn't saying that everything online is rubbish. I think there are a few accounts out there that are a little bit suspect in terms of their accuracy, and there is a tendency for people to think that, you know, everybody's a little bit autistic or everybody's got ADHD, and I think that isn't a helpful message.
I think from my perspective, I think getting used to the idea that this is autism and this is, you know, a natural variation of humans, that's a really positive element of online presence. I think in terms of normalizing especially some of the more extreme behaviors, I think we should be a little bit wary on that, because although it, you know, a meltdown does happen for quite a lot of autistic people, if not all, it doesn't always look the same, and you do fall into a trap of this is what a meltdown looks like. All autistic people have this kind of meltdown. Let's normalize that meltdown. Because actually, when you do get, you know, a violent meltdown, and I mean violent, that sort of thing shouldn't be normalized. It accepted as relating to autism, but it shouldn't be normalized. So I think there's a very, very fine line to walk, and I've certainly seen some sites which get it very well and some which just, yeah, don't. So yeah, you need to be critical, I think, when you're looking at this content, which I'm sure you are.
Could I ask a question, please? And I hope it's not too specific, but my daughter has bipolar and was diagnosed about 5 years ago, and she's on a very high dose of quetiapine, and her psychiatrist said, I can't up it anymore. And funnily enough, today she's texted me and said he thinks I have ADHD as well. So I suppose my question is if she's on quetiapine and sertraline and she's not bipolar, and she perhaps is autistic and ADHD, is quetiapine messing with her even more? Sorry, that's a bit specific.
I think it's probably out of our area of expertise to talk about specific medications, because I know that there's a huge overlap between autism and bipolar disorder. I wouldn't really want to comment on different medications, because you'd need to know the whole background, and yeah, it's a bit difficult to comment, really.
Yeah, I mean, even my own experiences of medication are not, we're different people. I can't, yeah, furthering what Judy said.
Sophie, just one other question about when you went through that period of overwhelm. So if you considered yourself in a hypothetical way going back before then, and if you weren't in a system like the schooling system is, and it was, say, maybe you were in a forest school, or you were just in the outdoors, or you were in a natural environment, not having to be controlled or conformed, would you agree that some of your symptoms would have been easier, or you would have felt sort of more at peace?
So the short answer is yes. I think I was very, very concerned with fitting in and conforming and being the perfect student whilst not standing out. So if my parents had suggested, or, you know, it was somehow possible for me to leave that pressurized environment and go to an alternative school, I would have refused, because I very much wanted to be mainstream. I wanted to learn. So I think if the pressure was reduced, if there wasn't as much homework, if the exams weren't so important, I think I wouldn't have gotten so caught up in it. I'm sure I would have had other difficulties. Whether they would have been as bad is a different matter. But I think for me personally, it would have to be the whole school system was different. Otherwise, I would feel like I was different. I was standing out. I was wrong. Yeah. Does that answer your question?
I think I have a grandson who I've talked about with Sophie several times, who I think is a poster boy for a PDA child. We call him Bear Grylls, because he's completely on his own agenda. He's happiest being outdoors, doing his own thing. And I think for him, something like a forest school or something that was less structured would be ideal, because he is not the easiest child in the classroom to manage or to support, because he wants to do his own thing. And I always imagine that if we were going back 300 or 400 years ago, he probably would have been the little boy that was out in the fields helping the farmer, or was making things, helping somebody do woodwork or something. I just think that for some children, that very restrictive school environment just doesn't suit who they are. And maybe that's why there are more children today who are struggling with school, because it is so restrictive and it's so results driven. So I guess it's different, isn't it, for different children?
So I guess this comes into the whole what we were talking about earlier, internalizing your PDA and externalizing it, because I was the internalizing when I wanted to fit in, whereas if grandson's externalizing, then he's probably better suited to it.
I don't think fitting in would occur to him particularly. He's great.
I have another online question. Where can I get support to help my child understand autism?
Get support. It depends whether you mean resources like books, or there are Jessica Kingsley does a number of good books for autistic children. In terms of trying to access support through CAM services, they may not be able to offer, but anything that offers psychoeducation or offers the opportunity to learn about autism or to understand your own feelings, so the zones of regulation stuff, anything like that is helpful. but unfortunately it tends to fall on parents and carers because the services are just not there to support that kind of thing. It should be, but they're not. So I think a good starting point would be the Jessica Kingsley website. They've got some excellent books for young people.
Just a final kind of point, really. So obviously, Credi and Ceredigion, we're here to support parent carers of all types, ages. And we have got a PDA parents group, which will be meeting downstairs at the end of this session in the food hall. So if anyone wants to come along, the cup of tea will be on us. And we meet monthly. And I think that for the people who come, it's been really important to kind of come together with other parents. And we've learned a lot together over the last few years since it started. And there are other parent carer groups around the county. So come and grab us if you want to find out more about that. And I also wanted to say that this whole series came about because of a parent carer who was hearing from lots of other people, as we do as well, about wanting more awareness of these conditions, wanting to make sure that parents feel heard and supported, and that professionals around us get a chance to hear about this stuff. So this whole series came about as a result of a parent carer standing up and going, I want something different. And just for everybody here to know that we're here for you. So if you want to do something, or if you want to have your voice heard, or if you think that there's something that should be that isn't at the moment, just always come and talk to us. So yeah.
Okay, we've come to the end. Oh, sorry.
No, that's okay. I just wanted, it was an information point, which is that Luke Clements and the team at Cerebra have just brought out some research about trauma in parent carers, and that that might be quite useful for people to know about and look up.
Yeah, actually, I work, and Judy, I think Judy does as well. I work with Luke a lot, and Andy Bilson, and I was looking at the research today, reading it through. There was a conference on Tuesday about it in London, which I was going to go to and then I couldn't. But it is really worth reading. There's an abbreviated version as well. So, and there's a lot of work nationally. Judy and I are part of this on looking at parent blame, and we actually are challenging the Royal College of Paediatrics and Child Health to remove the fabricated or induced illness label, because it's not a diagnosis, because it's causing so much harm to so many families across the UK. So, okay, there's another question.
For those of us who will lose the notes or haven't even made notes, is there a way to get all these extra bits of information, like the Cerebra, things that Sophie said, things that Judy said, things that you said, put down even in a list and on an email, just saying these were discussed, so that then we can go and look at the links and we won't lose them?
It's in the process of being finalised. There's a new website coming out which is looking at fabricated or induced illness and parent blame. Judy and I were at a meeting yesterday about this. So when that happens, I will pass the link on so that people can access that. I think there'll be a lot of incredibly useful resources on there for people to look at. So, Judy and Sophie, is there anything you want to add before we finish?
Just saying thank you for, I guess, having us today. And I really hope we've helped. Yeah, something.
Yeah.
Sorry. Okay. Yeah. Yeah, thank you both for joining me and the group here, and also for sort of coping with the technical problems, which weren't too massive, but I know that they sort of can add stress as well. So thank you both. I really appreciate working with you.
Same here, Kathy, and thanks to Sophie as well.
There is going to be a part 2 sometime next year. And right, okay. And Judy, we'll wait to hear whether or not you're coming in person. So we'll see. Yeah. No pressure, but it would be lovely to have you here.
It's about the furthest part of the country to travel to. I live on the east side of the country, and you're on the complete west side of the country. So
yeah, fair enough.
But I may come for a holiday. I haven't been to Wales for a while, so I think it would be a nice opportunity to make a break of it.
Yeah.
Just to note, there are some save the date flyers for the next workshop on the table by the door.